Assalamu alaikum. I am Dr. Momina Malik, and today I will be presenting a case with the title of light blindness. A 33-year-old male, welder by occupation, unmarried, resident of Rajanpur, Punjab, presented to the outpatient department of Mughal Eye Hospital with a complaint of sudden decrease in vision in both eyes since 2 months. The patient was in his usual state of health about 2 months back when he experienced sudden painless decrease in central vision, which progressively deteriorated over time. Metamorphopsia was present. Peripheral vision was intact according to the patient. There was no associated pain, floaters, or flashes of light. No specific aggravating or relieving factors were noted by the patient. There was no history of use of glasses, lasers, surgery, trauma, or injections within the eye. When the patient first experienced the symptoms, he went to a local hospital from where he was prescribed topical lubricants, which the patient was still using by the time he presented to us. The patient was non-diabetic, non-hypertensive. The systemic history, past medical and past surgical histories were insignificant. The family history was unremarkable for such illness. The patient was a non-smoker, non-addict, with normal appetite and normal sleep-wake cycle, and belonged to a middle-class family. Moving on to the examination. The best corrected visual acuity of both eyes, right and left, was 6/18. The cornea was clear. Conjunctival congestion was present in both eyes, more marked in the left as compared to right. Intraocular pressure was 14 millimeter of mercury in the right eye and 15 millimeter of mercury in the left eye. Anterior chamber was quiet. Both pupils were equally reactive to light and accommodation, and RAPD was negative. The lens was clear as was the vitreous. On dilated fundus examination, a well circumscribed round yellow lesion less than 1/4 disc diameter was seen at the center of the macula of both eyes. The rest of the fundus was within normal limits. Amsler grid testing was done, which revealed bilateral central scotomas. This is the fundus photograph of the patient, of the right eye as well as the left eye. As you can see, the disc, it has well-defined margins with normal contour, and the vasculature is normal as well in both eyes. However, if we focus at the macula, we can see that there is a well-circumscribed, round, yellowish lesion, which is less than 1/4 of the disc diameter, and it is exactly at the center of the macula. So based on the history and the examination, the following differential diagnoses were made. Our top differential was solar retinopathy, as the patient had been doing welding since 8 to 10 years. Then we had Best vitelliform macular dystrophy, especially the adult onset type, which also starts by the age of 30 years. However, to differentiate this, we have to do EOG and ERG, which is in EOG, it is subnormal in Best disease. And the characteristic yolk-like lesion in Best disease, it is of bigger size, around 1500 to 1700 microns. Bilateral macular hole was also a differential, and cystoid macular edema. So in order to reach a definitive diagnosis, OCT macula of the patient was done. This is the OCT macula of the patient, of the right eye and the left eye. We can see that the central macular thickness is 263 microns in the right eye and 273 in the left eye. No PVD, VMT or VMA were noted. The foveal contour was normal in both the eyes, and the retinal layers had normal thickness and architecture. However, if we look at the subfoveal ISOS junction or the ellipsoid region, there is abrupt disruption noted in both eyes, and this is characteristic of solar retinopathy. So after the investigations were carried out, a definitive diagnosis of solar retinopathy was made. Now, as solar retinopathy, if for the first 6 months, it is a self-limiting disease and it improves on its own. So counseling of the patient was very important. The patient was counseled regarding the aggravating factor and the high intensity light source from the welding, which was most likely responsible for the development of this disease. He was called for follow-up every 2 months for 6 months. At the first 2-month follow-up, the patient had left welding through this time period. The best corrected visual acuity was still 6 by 18 in both eyes. However, the patient himself was reporting to have gained slight improvement in the vision. And the patient is still on follow up with our hospital. So we'll go through the literature review. Solar or photic retinopathy refers to a pathophysiological entity which causes visual disturbance sustained during or after prolonged or high intensity exposure of the foviomacular retinal tissue to light energy. The photochemical injury to the eye is either by the production of free radicals or reactive oxygen species. When the light encounters the molecules of the retina, the electrons they get excited, and when they return back to the ground state, it results in the formation of free radical formation. And direct stimulation of high intensity sustained light on the molecules will lead to the formation of reactive oxygen species as well. And both of these are the criminals for the development of solar retinopathy. The risk factor first and foremost is sustained high intensity light exposure, young age, clear intraocular lens, and photosensitizing drugs such as tetracyclines. And the protective factors are high refractive error, cataract, or darkly pigmented fundi. Now, as for any disease, in order to reach a diagnosis, the history examination and the investigations are very important. But specifically for this disease, the history holds great importance because we have to take a detailed history and identify or if any such incident was encountered in which high intensity light beam was focused in the eye. The patient presents within hours of exposure usually, and the symptoms they include blurred vision or central or paracentric blind spots in one eye or both eyes as well. The patient can also complain of metamorphopsia, micropsia, or even he can present with headache as well. The signs are decreased visual acuity. It can range from 6.9 to even as worse as 6.60, depending upon the extent of exposure of the patient. The mild cases, they may show no fundus abnormalities, and we'll just observe those patients. More moderate to severe cases can show dynamic fundus changes. Within the first few days, a yellow-white spot is seen on the fovea, and then the spot it takes on a reddish hue, which is often surrounded by a halo of pigment. And after 2 to 3 weeks, a small 100 to 200 micron foveal depression is seen in the eye exposed to the light. This is a 50-year-old woman who had repeatedly been staring at the sun for long periods of time. This is the OCT, and as you can see here as well, there is subfoveal abrupt disruption of the ellipsoid region. This is the colored fundus photogram of the same patient, in which we see a well-circumscribed yellowish lesion at the center of the macula. And this is the fluorescein angiography. In the right eye, you can see that there is staining at the center of the lesion. And in the left eye, you can see that there is a central hypofluorescent spot with surrounding hyperfluorescent area. The central hypofluorescence is due to pigment clumping, and because of the window defect, the hypofluorescence is present. Moving to the management, primary prevention is the key. And no known medication has proved to effectively treat this disease. So follow-up visits are done at acute stage to monitor the progression, as was being done for this patient. The prognosis, the bulk of the visual acuity, it will improve between 1st to the 6 months after the phototoxic event has occurred. Even if moderate vision loss is present at presentation, most of the patients, they ultimately return to the visual acuity of 6.6 or 6/9. Improvement has been seen to be achieved earlier if at presentation, initial presentation, the patient has good vision. If they present early, the final visual outcome will also be better. However, metamorphopsia or the central or paracentral scotomas, even if they may show improvement initially, it has been seen that they often become permanent in this disease. So this was a case which was published in December 21 in the Journal of Medical Case Reports with the title Managing Solar Retinopathy with Suprachoroidal Triamcinolone Acetate Injection in a Young Girl. So a 17-year girl, she presented after looking at the sun while taking a selfie. So it was that brief of a time. And she presented initially with the vision of 6 by 18 to the clinic, and 2 months had passed and there was no improvement in the vision seen. And after that, triamcinolone acetonide injection was planned for that girl, while counseling about the side effects that intraocular pressure can occur or cataract formation can occur as well. So we look at the serial OCT scans of that girl. So this is the first OCT at the time of presentation when the visual acuity was 618. You can see there is disruption of the ellipsoid region with overlying hyperreflectivity, as you can see over here. This is due to inflammatory reaction. Now, after 1 month, the OCT scan was repeated. Till now, no treatment was given. And you can see that still there is discontinuity in the ellipsoid region, but the overlying hyperreflectivity has been improved from the previous scan. So a suprachoroidal triamcinolone acetonide injection was given to this girl, and this is 1 week post suprachoroidal injection. So you can see that the tissue reaction, it has resolved completely, and the discontinuity, it is still present 1 week post injection. This is the OCT scan of 1 month post suprachoroidal injection, and you can see there is reappearance of the ellipsoid zone signal, but there's still slight disturbance of the interdigitation zone. This is 2 month post injection, which shows mild disturbance. It is improving with each scan. And after 3 months, the visual acuity had improved to 6 by 7.5. And there is only slight disturbance here as well, with marked improvement from the previous scans. And 4 months post injection, the visual acuity had improved to 6 by 6. And you can see that the OCT is completely normal of this girl. So the conclusion was that suprachoroidal triamcinolone acetonide injection using a custom-made needle showed both functional and anatomical improvement of macular changes post-solar retinopathy with acceptable safety outcomes in a young female. This girl, she experienced raised intraocular pressure during the 7th week, and it raised up to 28 millimeter of mercury, but it was settled down with topical beta blockers. So the side effect was also combated. So the take-home message for us is that early diagnosis and counseling of the patient can lead to better final visual outcome. Any patient who gives history of prolonged or intensive light exposure should always be dilated, and the fundus should be seen once. Also, the Amsler grid testing is a very quick and effective way to monitor the macular function, and it hardly takes any time. So the patient who is presenting with a metamorphopsia or such complaint, even if the visual acuity is good, it only takes about 1 to 2 minutes. We should always do the Amsler grid and have an assessment of the macular function. Thank you.
Okay, well done. See, the first thing is that patient complained of central scotoma. So, and you did Amsler grid. So, in Amsler grid, we ask the patient to draw which is the area where the patient cannot see, and you ask the patient to make a diagram. So, you should have presented the diagram so that we know what is the extent of the scotoma. See, is it pinpoint, occupying how much of the area? So, whatever the investigations, we have to sort of present them. This is, and in such academic cases, you have to make all the investigations which are necessary to rule out the differential diagnosis. If you are considering best vitelliform, you may go for EOG and ERG. ERG is available next door to us, right across the canal in the CEMB. See, they are doing, yeah. So whenever you are presenting a case, you have to make all the relevant investigations. This is one thing. Second thing is that I have stressed many times, there are different levels of scientific evidence. You see, the weakest is anecdotal. I say, give injection this. Tariq Saab said, to give this injection because I find it useful. This is personal opinion. This is anybody having his opinion about the treatment. Okay, we respect this, but this is the weakest evidence. The next stage is case reports and case series, where one patient was documented having improvement, or in a case series, number of patients were found to have beneficial effects. So this is the lowest evidence, better than anecdotal, but there is some scientific evidence. But a step forward is randomized control trials, in which you get 10 patients of suspected solar retinopathy and divide them into two groups. One is control group and the other is experimental group. Randomization. You randomly distribute the 10 in two groups, so that once you give treatment in one group and you see whether there is any appreciable difference between the two groups. So this is the evidence you are looking for. If a randomized controlled trial or RCT tells you that okay, this treatment is beneficial, then you advocate that treatment, you do that treatment, you propagate that treatment. And when you combine multiple RCTs, this is called meta-analysis. So meta-analysis pulls up the RCTs. Okay, in this RCT there were 10 patients, in this RCT there were 20 patients, in this RCT there were 100 patients. So a total of 130 patients were given this treatment, half of them control, half of them, and this was the beneficial overall. So that is the strongest evidence. So my recommendation is that instead of picking up a case report or a case series having one or two or three cases, you go preferably for meta-analysis. Okay, this is the conclusion on this topic. So if you don't find meta-analysis, then at least it should be a randomized controlled trial, a study which has a control. So you consider only strong scientific evidence, not weak scientific evidences. You see, and if you have sort of picked up a case report, you see how many similar case reports are in the literature. So you don't sort of advocate the lessons or conclusions of single case report. So you have made a conclusion. So, is it justifiable to sort of conclude on a single case report? A person has injected triamcinolone and now you are advocating, okay, give triamcinolone. What is the rest of the world telling you? You have to review the literature and find out how many opinions are there. Who says that give injection and who says don't give injection, it will not be useful. So you should have a panoramic view, not limited to one article. See, so this is the purpose of review of literature, that on that topic, what is the international opinion? What is the consensus that has been reached? You should not be biased by one paper or article. I have seen many a time the person says, in this treatment, in this disease, give carrots. Okay. So what is the evidence? Many people, so we have to stick to the scientific procedure.
Yes. So this was an ultraviolet protect treatment. This is an unusual presentation. What is the most common presentation? Cataract long-term develop होगा. Hmm. Okay, these are all long-term. Short-term, immediate effect of this. Photophobia, yes, one, another. देखिए जैसे इन्होंने लिखा ना लाइट ब्लाइंडनेस, इसी तरह एक है स्नो ब्लाइंडनेस और इसी तरह ये वेंडिंग आर्क कैरेटाइटिस. Basically, what happens that when it is short term exposure, even आप लोगों ने जो मेल मेंबर्स हैं कभी उन्होंने देखा होगा कि वेल्डिंग देखते हैं थोड़ी देर और उसके बाद रात को पेन के साथ आते हैं पेशेंट. अक्सर बात ये होता है कि आप नाइट ड्यूटी पे हैं 8 बजे 9 बजे या समटाइम लेट आवर्स में एक पेशेंट आता है विद वाटरिंग फोटोफोबिया अनएबल टू ओपन दी आईज, और उसको शदीद पेन में होता है। ठीक है, आप हिस्ट्री लेते हैं, हिस्ट्री लेने के बाद पता चलता है कि उसने दिन में वेल्डिंग कहीं हो रही थी, अचानक उसने देखा विदाउट एनी प्रोटेक्टिंग ग्लासेस। इवन जो वेल्डिंग वाले भी हैं, इफ दे आर नॉट यूजिंग दो प्रोटेक्टिव ग्लासेस, तो उस अल्ट्रा वायलेट लाइट की वजह से जो सबसे पहला इफेक्ट होता है वो है कॉर्नियल एपिथेलियम। ठीक है, इनिशियली कुछ नहीं होता, नॉट एट आफ्टर 6 to 7 hours those epithelial cells which have absorbed that ultraviolet light, they start, ठीक है, दे डिग्रेड, और उसके बाद देर आर punctate epithelial erosions, and because of that erosions there is the corneal nerve fibers, they are exposed, and that is the resultant of severe pain, photophobia, unable to close the eyes. So this is the most common presentation, जिसको हम वेल्डिंग आर्क केराटिटिस के नाम से कहते हैं। तो ये आपके पास आते हैं, और उस वक्त क्या करना है, वेरी डिफिकल्ट। उसमें सिर्फ आपने क्या करना है, एट द मोमेंट उसको लोकल एनेस्थेटिक डाल के अच्छी तरह एग्जामिन करें। आफ्टर द एग्जामिनेशन व्हाट यू डू, यू गिव टाइम फॉर दोज एपिथेलियल सेल्स टू रीजनरेट। ठीक है, यूजुअली ओवरनाइट आप उसको ऑइंटमेंट देते हैं, वो हीलिंग देते हैं, और अगले पैड करते हैं, और नेक्स्ट मॉर्निंग तक वो काफ़ी हद तक बेहतर होता है। हल्का सा स्टीरॉइड ऐड कर सकते हैं उसके अंदर, बट द मोस्ट कॉमन प्रेजेंटेशन यही होती है कि रात बड़ी पेन में होता है। तो ये आप क्योंकि यहाँ पे आप इस तरह इमरजेंसी में एक्सपोज नहीं है, तो यू आर नॉट सीइंग दीज केसेस। लेकिन कभी ऐसी प्रेजेंटेशन जहाँ होंगे आप, जहाँ इंडिपेंडेंटली काम कर रहे होंगे, तो वहाँ इस तरह के केसेस बहुत आएंगे। सो दिस इज वन ऑफ द मोस्ट कॉमन एपिथेलियल केराटिटिस है presentation। इसी तरह इसकी एक हम एग्जांपल, ये आपको एक स्टोरी सुनाने का पर्पज ये होता है कि आपको वो चीज़ याद है। आई वॉज इन गिलगित, तो वहाँ पे इसी तरह कोई एक एक्टिविटी थी कि हमें चाइना से कुछ चीज़ें जल्दी पाकिस्तान पहुँचानी थी, और टाइम था फरवरी मार्च। देयर वाज ऑल स्नो, स्नो इतनी ज़्यादा थी कि अब एक बटालियन को पूरा टाइम, एक टास्क दिया गया कि जी आपने 2 दिन के अंदर अंदर ये रोड क्लियर करनी। पूरी पूरी बटालियन दे स्टार्टेड विद। अब वहाँ पे इतनी रिफ्लेक्शन होती है अल्ट्रा वायलेट फ्रॉम द स्नो कि वो जो दिन में लोग काम कर रहे थे, दिन भर काम करते रहे, उसका कुछ भी नहीं हुआ, बट वाइल एट नाइट सारे के सारे जो है वो टेयरिंग, रेडनेस, आंखें बंद और फिर सो दे हैड दिस एक्सपोजर। सो इसीलिए जब आप देखें कि स्नो जाते हैं लोग, तो दे यूज स्पेशल ग्लासेस और यूवी प्रोटेक्शन वाले ग्लासेस। इसी तरह आप सी पे जाते हैं, तो सी से भी इस तरह रिफ्लेक्ट होती है। तो दीज आर, सो इन सब चीज़ों में प्रोटेक्शन इज वेरी इंपॉर्टेंट, कि आपने प्रोटेक्टिव ग्लासेस और इन चीज़ों के बगैर नहीं। काउंसलिंग जो पेशेंट को करनी है वो यही करनी है, नेक्स्ट टाइम जब भी करना है विदाउट प्रोटेक्टिव ग्लासेस आपको।
One more point, I've been repeating, telling you that when you say the patient is having decreased vision for the last 2 days, for the last 2 weeks, for the last 1 month, for the last 1 year, so when the time period is not sort of specified, it is for. But when we specify that from this point, let's say since Friday, since January, since 1965. So whenever the time period is specified, this you use the word since. So there is a slight difference between when you use for and when you use since. So this is one thing. Second thing is the slides have improved a lot, but there are a few slides still which have a paragraph. You see, you don't write sort of paragraph sentences. Make bullets. In one line there should be 4 or 5 words. ठीक है, इसको थोड़ा सा प्रेजेंटेशन को पीछे करें, अब वो आगे करें। ठीक है, आगे करें। हाँ, सो when instead of writing sentences, you write the main message. See, next, आगे. सो ये सारी स्लाइडें ठीक हैं, गुड, यू हैव मेड पॉइंट्स, नेक्स्ट एक्सेप्टेबल, ओके, आगे आगे और आगे, the slides are not overcrowded, this is plus point, uh, where the symptoms, the complaint, see, बस ये पिछले वाला कर दो. So when once you have written symptoms on the top, then you write again symptoms commonly present. You don't have to write this word symptoms. Just if you want to start commonly present within hours. This is one bullet. Next bullet, include blurry vision and central or paracentral blind spot. Next bullet, additional complaints may include. There is no need of writing additional complaints may include. You have to write bullet dyschromatopsia, metamorphopsia, micropsia. So make it in a concise form instead of writing sentences. So ठीक है, बस.